Welcome back to the deep dive. Today we are discussing what I like to call the ultimate medical reset button. Imagine for a second that you're looking at a machine, a complex high-performance engine, and it's sputtering, it's failing. It is just broken beyond repair.
Right.
You can't patch it with duct tape, you can't tune it up, and you definitely can't ignore the warning lights anymore. The only option left is to physically rip that engine out and drop in a completely new one.
And that engine is the human heart or the lungs.
Exactly.
Really is the nuclear option of medicine, isn't it? It is, it's arguably the most dramatic high-stakes intervention we have.
It has to be.
It's the procedure that transforms a terminal diagnosis, basically a death sentence, into a second chance at life. But it's not just about the drama of the OR, though that's certainly there.
Right.
It's about the immense biological complexity of making one person's organ survive in another person's body against, all evolutionary odds.
Exactly. And to guide us through this whole intricate landscape, we're doing a deep dive specifically into Chapter 92 of Baily and Love's Short Practice of Surgery.
The 28th edition.
The 28th edition.
Yeah.
This is the heart and lung transplantation chapter.
And I think we should set a mission statement right up front here.
Let's do it.
We are synthesizing this chapter. We're interpreting the dense medical text to pull out the narratives, the logic, and the why behind the facts.
Yeah.
So if you're a medical student or a surgical aspirant, prepping for exams, think of this as your high-yield conceptual framework. We're just trying to make the density of the textbook, digestible.
Right. Think of this as your ready reckoner. We're going to turn that textbook chapter into a conversation, but, and this is so important, for the fine print. The exact drug dosages, the specific survival curves, all the nitty-gritty details. You absolutely need to open the book.
Please do.
Read the actual chapter. Use this to build your mental scaffolding, but you have to fill in the bricks with the text.
Couldn't agree more. Knowledge is only useful if it's precise, especially in surgery.
So looking at our roadmap today, we have a massive journey. We're going to look at the history, which frankly sounds a bit like science fiction.
It really does.
We'll break down the fundamentals of heart transplants, the rise of the machines, those mechanical hearts bridging the gap, and then we'll move upstairs to the lungs, which have their own set of very specific, tricky rules.
It's a great roadmap. And honestly, starting with history is the only way to appreciate where we are. Because science fiction is the right term. We take transplantation for granted now. But if you go back to the 1940s, this was the realm of mad science.
They're talking about Vladimir Demikov.
I am. In Russia in the 1940s and 50s, Demikov was doing experiments that sound unbelievable today.
Like what?
He was transplanting hearts and even heart-lung blocks into animals. He was famously creating two-headed dogs in some experiments just to prove vascular connectivity.
Two-headed dog.
I know. It was controversial, of course, and visually shocking, but he was pushing the boundaries of what was surgically possible. He proved you could technically plumb these things in and have blood flow.
But the leap to humans wasn't a straight line from there. It wasn't just, okay, the dog lived, let's do a person.
No, not at all. The first attempt involving a human recipient, it wasn't actually human to human. That was James Hardy in 1964. He transplanted a chimpanzee heart into a human patient.
A chimpanzee heart? That sounds incredibly desperate.
It was pure desperation. The patient was in terminal failure, literally dying, and there's no human donor available. Hardy made the call. It didn't work long-term. The chimp heart was just. It was too small to support a human circulation, and it failed very quickly. But it proved the technical feasibility. It proved you could sew a heart into a human chest and have it beat, even if only for a short time.
And that paved the way for the big one, 1967.
The moment the world changed. Christian Barnard in South Africa.
The first successful human-to-human heart transplant.
Yes. We say successful, but we have to define that really carefully. The surgery was a technical success. The patient woke up, which was huge. But in those early days, the patients didn't live long at all.
Because of rejection, right?
Exactly. They could sew the heart in. And they were standing on the shoulders of giants like Norman Shumway and Richard Lower at Stanford who developed the actual sewing techniques. But they couldn't stop the body from attacking it.
Right.
The immune system is a ruthless defender. It sees foreign protein and it just attacks. Mortality was incredibly high until the 1980s.
What changed in the 80s?
The discovery of cyclosporin. It was a fungal metabolite that turned out to be a potent calcineurin inhibitor.
Okay.
That changed the game. Completely. It allowed us to dampen the immune system just enough to tolerate the organ without completely destroying the patient's ability to fight off every other germ. Now, thanks to drugs like that, we're looking at a 1-year survival rate of over 90%.
That is a massive shift. So let's get into the nuts and bolts of the heart itself. If I have heart failure, I can't just walk in and ask for a new one like I'm ordering a part for my car.
Not quite.
So who actually gets a transplant?
This is where we talk about the transplant window, and I want you, the listener, to visualize a Goldilocks zone.
Okay, let's unpack that. The Goldilocks zone.
You have to be sick enough to justify the immense risk. I mean, we're talking about end-stage heart failure. In clinical terms, that's New York Heart Association class 3 or 4.
Meaning
You can barely climb a flight of stairs or maybe even brush your teeth without getting breathless. Your prognosis without the transplant is likely less than a year. You're really at the end of the road.
so really, really sick.
Yes. But, and here is the just right part of Goldilocks, you also have to be robust enough to survive the operation. If you're too frail, or if your other organs, your liver, your kidneys, are completely shot beyond repair, you won't survive the surgery. You have to be in that narrow window between too healthy to need it and too sick to survive it.
And generally, what diseases are landing people in that window?
The big two are dilated cardiomyopathy. That's where the heart muscle gets thin and flabby and weak, sort of like an overstretched balloon.
Okay.
And ischemic cardiomyopathy, which is a heart that's been damaged by blocked arteries and repeated heart attacks.
Now, I know there's a list of absolutely not the contraindications, the gatekeepers. What gets you kicked off the list?
Active infection is the big absolute one. If you have active sepsis or pneumonia, and we give you massive immunosuppression to stop you rejecting the heart, that infection will just run riot.
It'll kill you.
It will kill you instantly. Malignancy cancer is another. You usually need to be cancer-free for a significant period, usually 2 to 5 years, because, again, immunosuppression can make hidden cancer cells just explode.
What about lifestyle factors, like smoking or weight?
Those fall into what we call relative or complex contraindications. A body mass index, or BMI, over 30 is associated with significantly worse outcomes, wound healing issues, diabetes, infection.
So patients are told to lose weight?
Often, yes.
Yeah.
They have to lose weight to get on the list. And substance abuse, including smoking, is a major hurdle. Baily and Love is very clear here. A relapse of smoking leads to poor outcomes. You have to prove you can adhere to a strict lifestyle.
There's one specific contraindication in the chapter that seems really technical, but the book highlights it heavily. Pulmonary vascular resistance, PVR. Why is that such a deal breaker?
This is a critical concept, and it's often a favorite exam topic, so listen up closely. This is the memory anchor for this section.
Okay.
I want you to remember this phrase: the right heart is weak.
The right heart is weak. Okay, explain.
Let's look at anatomy. The left ventricle is the bodybuilder of the heart. It has thick, muscular walls because it has to pump blood to the entire body, to your brain, your toes, everywhere, against high pressure. The right ventricle, however, it only has to pump blood next door to the lungs. It's thin-walled, it's a low-pressure pump.
Okay, I'm with you. Bodybuilder on the left, couch potato on the right.
Exactly. Now, in chronic heart failure, blood backs up. Pressure builds up in the lungs. We call this pulmonary hypertension. If that pressure, the pulmonary vascular resistance, stays high for a long time, the vessels in the lungs stiffen up. They become like brick walls.
And what happens if you put a new heart in?
Well, the patient's old heart had years to adapt and thicken up to fight that pressure. But if you take a fresh, healthy donor heart and stitch it in, that new right ventricle is normal. It's thin.
Oh.
And suddenly it hits that brick wall of pressure in the patient's lungs. It just can't generate the force. It will dilate and fail immediately. We call this acute right ventricular failure.
So if the pressure in the lungs is permanently high, you can't put a new heart in because the new heart isn't strong enough on the right side to push through it.
Spot on. If the PVR is greater than 5 Wood units and it doesn't come down with vasodilators, it's a no-go for a standard heart transplant. The donor heart just can't handle the workload.
That is a crucial detail. I want to pause right there for our first check-in.
Let's do it.
Okay, listener, pause and think for a second. We just discussed a major physiological barrier to heart transplantation. Why is fixed high pulmonary vascular resistance a contraindication?
Hopefully you're picturing that thin-walled right ventricle. The answer is, the healthy donor heart's right ventricle is not conditioned to pump against high resistance. It will fail acutely, leading to immediate graft dysfunction and likely death. Remember, the right heart is weak.
Moving on. We have this Goldilocks window, but we have a massive problem in the real world. Supply and demand.
It's a huge discrepancy.
There are way more people failing than there are donor hearts available.
Yeah, and patients are deteriorating while they're waiting on the list. So we need a bridge. We need to buy time. This brings us to the rise of the machines, ventricular assist devices, or VADs.
I've seen diagrams of these. It looks like a little pump plumbed directly into the heart.
Yes. Specifically, the left ventricular assist device, or LVAD, is the most common. It takes blood from the apex, the bottom tip of the left ventricle, and pumps it directly into the aorta. It bypasses the failing heart muscle. It does the heavy lifting for the left ventricle.
And the book mentions something interesting about the flow. It's not like a heartbeat, right?
That's right. The early VADs, they tried to mimic the pulse, but they were big and clunky. The current generation uses a high-speed rotor. It provides continuous, non-pulsatile flow.
So if I met someone with one of these...
If you feel the wrist of someone with a modern LVAD, you might not feel a pulse.
No pulse.
No pulse. Even though they're walking around talking to you and very much alive. They have a mechanical hum, not a biological heartbeat.
That is wild. No pulse, but alive.
It's incredible technology. It's used as a bridge to transplantation, keeping them alive until a heart appears. Or, increasingly, as destination therapy for people who aren't candidates for a transplant but need support to live out their remaining years.
But it's not perfect. It comes with a heavy tax, you said.
It does. There's a trade-off. You have a mechanical rotor spinning in your blood that physically shears blood cells and activates platelets.
So you need blood thinners.
You need heavy blood thinners, which means a risk of bleeding. Specifically, strangely enough, gastrointestinal bleeding is very common. On the flip side, you have a risk of clots and stroke.
And infection.
Huge risk.
Yeah.
Remember, the device needs power. There is a cable called a drive line that comes out of the patient's skin and connects to a battery pack they wear.
Right.
That exit site is a direct highway for bacteria to get inside the body. Drive-line infections are a constant battle.
And I imagine having a machine installed makes the eventual transplant harder.
Much harder. The book notes that VADs cause vasoplegia, inflammation, and scarring. So when the surgeon goes in to take the VAD out and put the heart in, there are adhesions everywhere. It turns the standard surgery into a nightmare of dissection. You're basically chipping the old heart out of a block of concrete scar tissue.
Before we get to the surgery, what about the nuclear option? The book mentions ECMO.
ECMO, extracorporeal membrane oxygenation. That is for the patient in cardiogenic shock who is crashing right now. VADs take time to plan. ECMO is for the emergency room.
The last resort.
The absolute last resort. It pumps and oxygenates the blood outside the body. It can bridge you to a transplant, but the results are inferior compared to an elective procedure. It's a desperate measure to stop someone from dying within the hour.
Okay, so let's say we've bridged the patient, we found a donor. Let's talk about the operation itself, but first, we have to get the heart to the hospital. I always picture an ice cooler, like in the movies.
And surprisingly, that is still the standard. Cold ischemia.
Yeah.
You stop the heart, pack it in ice, and run. But you are racing a very tight clock.
How long do you have?
You only have about 3 to 4 hours. Time is muscle. If you go longer, the heart cells start to die from lack of oxygen.
But Baily and Love mentions a new tech that sounds way cooler. The organ care system.
Yes, the transmedic system. This is a paradigm shift. Instead of ice, you hook the donor heart up to a machine that pumps warm, oxygenated blood through it during transport.
So the heart is beating in a box in the back of the ambulance.
A warm, beating heart in a box. It allows for longer transport times, but crucially, it lets doctors assess the heart.
What do you mean?
See, normally, if a donor had a cardiac arrest, what we call donation after circulatory death, or DCD, we might be scared to use that heart. Is it damaged? Did the arrest hurt the muscle?
Right.
With this machine, we can restart it, watch it beat, check its lactate levels, and decide if it's good enough. It significantly expands the donor pool.
That is incredible. Okay, the heart arrives, the patient is on the table, chest is cracked, open median sternotomy, they're on bypass. How do you actually swap a heart?
It's called the orthotopic technique. You cut out the old heart, but, and here's the trick, you don't take everything. You leave a cuff of the left atrium. That is the back wall where the pulmonary veins bring oxygenated blood from the lungs.
Why leave the cuff?
Speed and simplicity. There are 4 pulmonary veins. Sewing them individually would take too long and be technically fiddly.
I see.
By leaving a cuff of the atrium, you just have one big anastomosis, one big circle to sew. You create a docking station.
Smart. So you sew the new heart to that cuff. What's next?
Exactly. Then you connect the pulmonary artery, then the aorta, and finally the vena cava, both the superior and inferior.
Plumbing complete. You take the clamps off, does it just start?
Usually, yes. It reperfuses, turns pink, and starts beating. It's the most magical moment in surgery.
Wow.
But then begins the danger zone. We face the 3 waves of complications.
Okay, walk us through the waves.
Wave 1 is immediate. Primary graft dysfunction. The heart is stunned. It's been without blood, it's been handled, it's been on ice. Sometimes the right ventricle, as we discussed, struggles.
Right, because of the pressure.
Exactly. You might need heavy drugs or even ECMO to support it for the first 24 to 48 hours while it wakes up. It's like waking up with a bad hangover. It just needs a moment.
And wave 2?
Rejection. This is the immune system waking up. Hyperacute rejection happens instantly on the table if blood types don't match. But that's rare now, thanks to careful cross-matching. The common one is acute cellular rejection, usually in the first few months. The body's T cells spot the intruder and attack.
How do you know it's happening?
You have to look for it. We do surveillance biopsies. We thread a catheter up a vein in the neck, down into the heart, and snip a tiny piece of the heart muscle to look under a microscope for T cells.
And the third wave? The long-term killer.
Chronic allograft vasculopathy, or CAV. This is the big bad of long-term survival. It's not like normal heart disease where you get a plaque in one spot. This is diffuse thickening of the coronary arteries all the way down to the tiny vessels. The arteries just slowly close up. It's an antibody-mediated process, very hard to treat.
And here's the scary part the book points out. The patient doesn't feel it.
Right. And this is a key physiological insight. When you transplant a heart, you cut the nerves. The vagus nerve, the sympathetic chain, they are severed. The new heart is denervated.
No connection to the brain.
There is no connection to the brain's pain centers.
So they can be having a massive heart attack and feel 0 chest pain.
0. No angina, no crushing weight on the chest. The first sign might be that they just collapse, or they get breathless because the pump is failing. That's why we have to monitor them so closely with angiograms. They have no warning system.
Wow. Okay, let's take a breath. That covers the heart. I want to do a mid-episode check-in right there, because that denervation point is huge.
It is fundamental.
So, listener, ask yourself, if a transplant patient has clogged arteries 5 years later, this chronic allograft vasculopathy, why don't they get angina or chest pain?
The answer. Because the heart is denervated. The nerves were severed during the surgery, so the warning system of pain is disconnected.
Okay, if you need to review the VAD complications or the types of rejection, hit rewind now. Otherwise, we are moving up the chest. Let's talk about lungs.
The lungs.
Yeah.
If the heart is a simple pump, the lungs are a complex, delicate filter. And honestly, they are the high-maintenance organ of the transplant world.
Why are they harder than hearts?
Well, think about where they are. The heart is sealed in a sterile sac inside the chest. The lungs are the only internal organ that is constantly exposed to the outside world.
Ooh.
Every breath brings in bacteria, fungal spores, pollution, dust. They're dirty.
And that makes them hard to donate.
It makes them incredibly fragile. Ideally, you want pristine lungs. But because of aspiration, pneumonia, or chest trauma during the donor's death, most donor lungs are damaged. The number is something like only about 20% of donor lungs are actually suitable for transplant.
Only 20%.
It's a massive scarcity crisis.
Who needs them? What does the list look like?
COPD emphysema is a big one. Cystic fibrosis, pulmonary fibrosis, which is scarring of the lungs, and pulmonary hypertension.
There's a scoring system mentioned, the LAS, or lung allocation score. It's not just first come, first served, is it?
No, and it shouldn't be. In the old days, it was time-based, but people were dying on the list. The LAS calculates urgency. How likely are you to die without it? Minus the probability of post-transplant survival.
Okay.
It prioritizes the sickest patients who still have a good shot at living. It really pushes people like pulmonary fibrosis patients who decline very, very fast to the top of the list.
There are some specific rules for lungs that stuck out to me, particularly for cystic fibrosis. The book says you essentially have to do a double lung transplant. You can't just replace one. Why?
This is a bad neighborhood problem. Cystic fibrosis is a systemic disease where the lungs are filled with thick, sticky mucus and chronic, deep-seated infections.
Right.
So if you take out the left lung and put in a shiny, new, clean one, but leave the old, infected right lung, what happens?
The infection just spills over.
Exactly. The native lung acts as a reservoir of pus and bacteria. It will spill over and destroy the new lung immediately. So for septic lung disease like CF or bronchiectasis, it's bilateral or nothing. You have to remove all the infected tissue.
That makes total sense. What about contraindications? Is there a lung equivalent to the active infection rule?
There's a specific bug, the book names, Burkholderia sanocepacia.
Okay.
It's a bacteria found in some CF patients. It is incredibly resistant to antibiotics and very aggressive. If a patient is colonized with that, it's often an absolute contraindication because it just rampages through the new organs post-transplant. It's a tragic reality for some young patients.
Now, we mentioned only 20% of lungs are good enough, but there's technology trying to fix that. We talked about the heart in a box. Is there a lung in a box?
There is. It's called EVLPX, Vivo Lung Perfusion. I like to call it lung rehab.
Lung rehab. Explain that.
Let's say you have a pair of donor lungs that are borderline. Maybe they're a bit wet, a bit of edema, or we aren't sure how well they exchange oxygen. In the old days, you'd trash them. Now, you put them in the EVLP machine, you ventilate them, warm them, and run a special hyperoncotic solution through them to dry them out.
You try to fix them up before you buy them, like renovating a house before you move in.
Perfect analogy. You recondition them. You can test them for 4 hours. If they improve, if the oxygen levels go up and the stiffness goes down, you transplant them. If they don't, you haven't risked the patient on the table. It allows us to use lungs we would have previously thrown away.
Let's talk about the surgery itself. The incision for a double lung transplant is dramatic.
It's the clamshell thoracotomy. You make a cut all the way across the chest from side to side, breaking the sternum in the middle. It opens up like a clam.
So,
Visually, it is one of the biggest, most aggressive incisions in surgery.
wow.
It gives you access to both chest cavities at once.
And plumbing-wise?
You connect the bronchus, which is the airway, the pulmonary artery, and the pulmonary veins via that left atrial cuff we talked about.
Yeah.
But there is a specific surgical nuance with the airway that is high yield for students. You have to keep the donor bronchus very short.
Why does length matter?
Blood supply. This is a subtle point.
Yeah.
The airway relies on tiny bronchial arteries. When you harvest the lung from the donor, you cut those arteries. You don't sew them back together. They're too small.
So the airway's blood supply is gone.
It's relying on backflow from the lung tissue itself to stay alive. It's living on borrowed blood.
Okay.
If you leave a long stump of airway, the end of it is too far from the lung tissue. It won't get enough blood. It will rot and fall apart. We call that anastomotic dehiscence. It's a disaster. So you cut it short to ensure it stays alive.
That is a high-stakes snip. So the lungs are in. What are the complications? We have the 3 waves for the heart. Is it similar?
Very similar structure. You have primary graft dysfunction. The lungs fill with fluid right away. This happens because of reperfusion injury. Then you have rejection. But the long-term enemy here is CLAD.
Clad.
Chronic lung allograft dysfunction. The most common form is bronchiolitis obliterans syndrome, or BOS. It's scarring of the tiny airways. The small tubes just scar down and close off.
So the patient slowly loses their breath again.
Yeah, it's devastating because it's usually irreversible.
And there's a weird connection mentioned between this lung scarring and acid reflux.
Yes, GERD, gastroesophageal reflux disease. This is fascinating. It turns out if you have acid reflux, you might be microaspirating tiny amounts of acid into your new lungs while you sleep.
Oh, wow.
That acid irritates the lungs and triggers the immune system to start scarring.
The stomach trying to sabotage the lungs?
Exactly. So treating reflux, sometimes even doing stomach surgery like a fundoplication, is actually a huge part of protecting the lung transplant.
Yeah.
It protects the lungs from the stomach.
All right, we've covered a lot of theory. Let's test it. I'm going to throw 2 fictional scenarios at you based on the chapter's rules. You tell me, transplant or no transplant?
Bring it on.
Scenario A, a 55-year-old male, end-stage COPD. He was a heavy smoker. He quit 2 months ago but is using nicotine patches. His BMI is 34.
Okay. So this is a tough one, but it's likely a no for now. Here's the analysis. The BMI of 34 that's a problem.
It's over 30.
It's over the 30 threshold, which implies poor outcomes, surgical difficulty. He needs to lose weight. But the bigger issue is the smoking. Quitting 2 months ago is a very short interval. The risk of relapse is just too high.
Right.
Baily and Love list substance abuse and smoking relapse as major red flags. He needs a longer period of abstinence, usually 6 months, and weight loss before he can get on that list.
Tough love, but necessary. Okay, scenario B. A 25-year-old female with cystic fibrosis. Her lungs are failing. She has a chronic infection with Burkholderia sanocepacia.
This is heartbreaking, but many centers would consider this a no or an absolute contraindication. That specific bacteria, Burkholderia, is associated with such poor post-op survival, often due to sepsis, that is often deemed futile.
So the risk is just too high.
The risk is that we use a scarce resource, 2 lungs, on a patient with a very low chance of survival. If she were a candidate, it would absolutely have to be a bilateral transplant to remove all the infected tissue. But the bug itself, it might disqualify her.
It really emphasizes how rigorous the selection has to be. We aren't just saving lives, we are managing a scarce resource.
That's the ethical weight the surgeon and the committee carry. Every yes to one patient is a no to another.
Before we wrap up, let's look at the future. Because as good as we're getting, we still don't have enough organs. What's on the horizon?
2 main frontiers: xenotransplantation and bioengineering.
Xenotransplantation using animal organs?
Yes. We mentioned the chimp heart earlier, but now the focus is on pigs. Pigs are anatomically similar to humans. The University of Maryland did a pig-to-human heart transplant in 2022.
But not just a farm pig, right?
No, a genetically modified pig. They used gene editing to make 10 specific changes. They knocked out the pig antigens that cause immediate rejection and knocked in human genes to make the heart look friendly to our immune system.
And it worked.
It worked for a short while, about 2 months. But rejection and porcine viruses are still huge hurdles.
And bioengineering. This sounds like ghost hearts.
That's a great term for it. The idea is you take a donor heart, maybe even a pig heart, and you wash away all the cells using detergent. You're left with a white, ghostly scaffold of connective tissue, the matrix.
And then?
Then you repopulate it with the patient's own stem cells. You grow a new heart on the old frame.
So no rejection.
Theoretically, because it's the patient's own cells, there would be no rejection, no immunosuppression needed. It's the Holy Grail. But we are still a long way from clinical reality.
It's amazing to think that the solution to organ shortage might be growing them in a lab.
It shifts the problem from a surgical one to a biological one.
So bringing it all back home, we've covered the history, the Goldilocks selection, the mechanics of VADs, the plumbing of the surgery, and the long-term battles with rejection. What is the one big takeaway you want the listener to hold on to?
For me, it's the shift in the battleground. In the 1960s, the challenge was mechanical. Could we sew it in? We've mastered the mechanics. The sewing is standard now. The battle today is entirely immunological, stopping rejection without killing the patient, and logistical, finding enough organs. The surgeon of the future needs to be as much an immunologist as a mechanic.
And for the students listening, remember, the right heart is weak regarding PVR. Remember why CF needs bilateral lungs. And remember that a denervated heart feels no pain.
Absolutely. Those are your exam nuggets.
And finally, a thought to leave you with. We talked about replacing the engine, but when you replace a heart, you aren't just replacing a pump. You are severing the connection between the brain and the heart. The nerves are cut.
Yeah.
The emotional heartache, the racing pulse of fear physiologically, that direct neural highway is broken, yet patients still feel emotion. It raises a fascinating question about where our feelings really come from if the highway to the heart is cut.
That is a deep philosophical rabbit hole.
Maybe a topic for another dive. Listeners, don't trust our summary alone. Go read Chapter 92. It is high yield, and the diagrams are worth 1,000 words.
Knowledge is only useful if applied.
Good luck with your revision. Thanks for listening to The Deep Dive. We'll catch you on the next one.